Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now let's get started. Today we're going to dive into the scientific publication with the title, Early Detection in Cases of Familial Breast Cancer Predisposition. What is appropriate and beneficial for the individual seeking advice? By Florian Demin and Suzanne Ditz. Asymptomatic women with a family history of breast cancer should first receive comprehensive and detailed counseling with a risk-benefit assessment of diagnostic or preventive measures. The medical counseling should enable individuals seeking advice to make a participatory decision. Despite now having good chances of cure and significantly improved survival rates, a diagnosis of breast cancer is perceived as potentially life-threatening and affects the entire family and friends. Fears of disease-specific and psychosocial limitations take center stage, along with the fear of a much too early end of life. This is particularly true when there is a suspected hereditary predisposition, which substantially increases the risk of developing breast cancer, especially at a young age. This article explains how individual risk can be determined and what to consider in risk counseling. In particular, it presents the option of intensified surveillance and possible alternatives. Assessment of the risk situation. To assess the risk situation, it is first necessary to examine the environment of the individual seeking advice. Concrete methodological guidelines for this are provided by the S3 Guideline for Breast Cancer from the Association of Scientific Medical Societies in Germany. The guidelines or recommendations of the Gynecological Oncology Working Group of the German Society of Gynecology and Obstetrics and the German Cancer Society, as well as the German Consortium for Hereditary Breast and Ovarian Cancer. The information and recommendations derived from these three organizations largely coincide for practical use. What risk groups exist? The risk of developing breast cancer over the course of one's life, referred to as lifetime risk, can be categorized into three classes. Based on the epidemiological understanding that approximately 1 in 8 women will develop breast cancer in their lifetime, the normal lifetime risk is 10 to 13%. High risk is classified at a lifetime risk of 30% for breast cancer, or at a 20% heterozygous risk for the presence of a breast cancer gene based on pedigree analysis. An intermediate risk is present when the lifetime risk falls between the two aforementioned risk groups. When is there a family history of breast cancer? Approximately 30% of all women with breast cancer have a family history of the disease. A family history is considered to be present when multiple women and possibly men in the biological relatives of the individual seeking advice have been diagnosed with breast cancer and/or ovarian cancer in specific constellations. In these constellations, a detection rate of at least 10% for genetic mutations can be expected. Thus, the inclusion criteria for a genetic investigation would be met. Therefore, before undergoing genetic testing, it is essential to have a risk counseling session to determine the individual's lifetime risk. Furthermore, it is important to ensure that the individual seeking advice is given sufficient time for consideration before undergoing genetic testing. Is she truly ready to handle the knowledge of the presence of a breast cancer gene, and thus a potentially existential threat, along with the associated consequences? Genetic factors. The currently most well-known risk genes are the breast cancer genes, breast cancer 1 and breast cancer 2. These were the first breast cancer genes discovered in the 1990s. Since that time, it has been understood that carriers of these genes develop breast cancer approximately 20 years earlier, have a lifetime risk of 50 to 80% for breast cancer, a contralateral breast, cancer risk of 60%, and a lifetime risk of 10 to 40% for ovarian cancer. In recent years, numerous variants of other gene regions that could be associated with breast cancer risk have been identified. To more accurately assess the significance of individual gene defects, two research groups from the USA and Europe have compiled data from case control studies. The EU-funded Breast Cancer Association Consortium examined the impact of a total of 34 gene variants on breast cancer risk. The analysis involved 44 studies with 113,927 women, 60,466 with breast cancer, and 53,461 healthy women as a control group from 25 countries. The U.S.-based Carriers Consortium focused on results from 12 cohorts that described the effect of 28 gene variants in 64,791 women, 32,247 with breast cancer, and 32,544 without breast cancer. Both studies found a significant association between breast cancer risk and genetic alterations in the following 8 genes: BRCA1, BRCA2, PALB2, BARD1, RAD51C, RAD51D, ATM, and CHEK2. The European study also identified a significant association with changes in the TP53 gene, while the U.S. study associated pathogenic variants of the CDH1 gene. For alterations in most of the other tested genes, a significant correlation with an elevated breast cancer risk could not be described. BRCA1 and BRCA2. Tip of the iceberg. The breast cancer 1 and breast cancer 2 genes stood out in both studies. In the U.S. study, an increase in breast cancer risk by a factor of 7.62 for BRCA1 variants and a factor of 5.23 for BRCA2 variants was determined. In the European study, the results were even more pronounced. The odds ratios were 10.57 for BRCA1 and 5.85 for BRCA2. PALB2 is also considered a high-risk gene. Moreover, pathogenic variants in the ADM and CHEK2 genes were associated with a lifetime risk of over 20%. Other moderately penetrant risk genes identified include BARD1, RAD51C, and RAD51D. Additionally, it was observed that different breast cancer subtypes are influenced by these gene variants in distinct ways. While alterations in BRCA1, BRCA2, and PALB2 were more frequently discovered in triple-negative breast cancer, women with mutations in the ADM or CHEK2 genes were more likely to have estrogen receptor-positive tumors. Increased risk in other cancer types. Pathogenic variants of breast cancer genes not only elevate the risk of developing breast cancer. Alterations in BRCA1 and BRCA2 also raise the risk of ovarian cancer in women and prostate cancer in men. Carriers of BRCA1 mutations have an elevated risk of colorectal cancer, while carriers of BRCA2 mutations are more susceptible to other cancer types than the average population. Mutations in the CHEK2 gene increase the risk of colorectal cancer. ADM mutations are possibly linked to an increased risk of pancreatic cancer. Other associations, such as between hereditary non-polyposis colorectal cancer and breast cancer, could not be confirmed. However, several other cancer syndromes are recognized to come with an elevated risk of breast cancer, such as Li-Fraumeni syndrome. Since some years now, commercially available gene panels have the capability to identify the presence of risk genes. Some of these provide a polygenetic risk score as a single value to estimate an individual's genetic susceptibility to developing cancer. Non-genetic risks. A specific risk situation arises following radiation therapy in the thoracic region. A typical scenario is radiation exposure to the thorax during childhood or adolescence, such as in cases of Hodgkin's lymphoma, leading to an increased risk of developing breast cancer. How lifetime risk is determined. The individual's lifetime risk of developing breast cancer is influenced not only by genetic factors, but also by a variety of other variables. Over the past years, several models have been introduced aiming to achieve both high predictive accuracy and user-friendly applicability. Currently, the Tyrer-Cuzick model achieves the highest predictive accuracy. It takes into account multiple genes and their penetrance family history, the endogenous hormone status, potential hormone replacement therapy, risk factors like age and BMI, and almost uniquely mammographic breast density. The model can be accessed free of charge via the web interface of the International Breast Cancer Intervention Study. What preventive measures for which level of risk? For individuals with a normal lifetime risk of breast cancer, participation in a systematic breast screening program is recommended. The basis of this approach is a mammography at 2-year intervals between the ages of 50 and 70 or 75. For a moderate risk situation, there are no standardized recommendations. In cases of a high-risk constellation, conservative methods of care are summarized under the term intensified surveillance. As a surgical measure, mastectomy is an option which involves removing the mammary gland and substantially reduces the risk of breast cancer. Bilateral prophylactic mastectomy gained public attention a few years ago when Angelina Jolie, a prominent individual facing a high-risk situation, openly discussed her experience. However, such a procedure can have significant psychological and psychosexual impacts on the individuals, an area that remains insufficiently explored. For carriers of BRCA1 or BRCA2 mutations, due to the increased risk of ovarian cancer, consideration should also be given to risk-reducing salpingo-oophorectomy. What is intensified surveillance? The goal of intensified surveillance is twofold: to detect newly occurring breast cancer as early as possible, while minimizing the potential harmful effects of diagnostic procedures. These harmful effects include not only physical damage from ionizing radiation exposure or biopsy-related effects, but also emotional distress reactions. The key aspects of intensified surveillance are therefore the choice of intervals and diagnostic methods. Regarding diagnostic methods, all known breast examination techniques are applicable for intensified surveillance. Clinical examination involving physical inspection, palpation, ultrasound, mammography, and magnetic resonance imaging with potential image-guided biopsies. Breast self-examination does not play a role within intensified surveillance. Compared to systematic breast cancer screening, intensified surveillance faces distinct challenges. These challenges include higher proliferation rates and faster growth of breast cancer-specific tumor biology as seen in BRCA1. Associated malignancies often presenting with a benign morphology and the relatively younger age at first manifestation, resulting in reduced breast tissue transparency in young women and consequently reduced mammography sensitivity for early detection. These characteristics are not accounted for in systematic breast cancer screening programs. For these reasons, recommendations from medical societies are based on the specific benefit-risk ratio of available methods in high-risk situations. The guideline from the Association of Scientific Medical Societies notes that the diagnostic accuracy of mammography and MRI is published, but a reduction in mortality through these methods in high-risk situations has not yet been proven. However, it is clear that intensified surveillance with MRI is capable of detecting breast cancers at an early stage. The impact of new genetic diagnostics, on the other hand, is still uncertain. Therefore, the Association of Scientific Medical Societies recommends intensified surveillance with mammography within a quality-assured program for women with pathogenic BRCA1 or BRCA2 mutations, and for women with a lifetime risk of greater than or equal to 30% due to other reasons. This recommendation is supported by recent data showing high negative predictive value and a sensitivity of nearly 90% for mammography. In a recent study comparing mammography, ultrasound, and mammography in a high-risk group, 21 to 36% of breast cancers were detectable solely through mammography, whereas only 1 to 3% were detected solely through ultrasound or mammography, respectively. The Gynecological Oncology Working Group recommends a multimodal approach to intensified surveillance starting at the age of 25, including semi-annual clinical breast examination and ultrasound, as well as annual mammography. Case presentation. Julia, a 36-year-old woman and mother of 2 daughters, has a 3-year younger sister who recently discovered a lump in her breast. Subsequent diagnosis confirmed breast cancer. Since then, Julia has been gripped by a strong fear that she might also be afflicted with breast cancer. Though she hasn't detected any lumps in her own breasts, Julia has been experiencing a sensation of pressure and occasional discomfort in both breasts lately. She is deeply concerned about whether these sensations could potentially be indicative of breast cancer. Seeking guidance, she schedules an appointment with her gynecologist and asks for advice on what steps she should take next. Fear. Experiencing fear is principally normal and healthy. Fear arises when we find ourselves in situations we are not yet equipped to handle or understand. The fear response has evolved over time to ensure human survival. Therefore, fear is not an illness in itself. It triggers actions for personal protection and self-care, such as seeking advice, undergoing genetic testing, and participating in an intensified surveillance program when facing a suspected or confirmed high-risk situation for breast cancer. The trigger for fear is not a specific perception, but rather how we evaluate that perception. When fear takes up increasing space and becomes an energy drain, it can reach a pathological level. Particularly when fear significantly impacts quality of life or daily functioning, psychological support might be necessary. What do the guidelines say? As a physician in the consultation room, we acknowledge and address Julia's fears and concerns. In the first step, it is important to recognize that we are not facing a patient, but an individual seeking advice. Therefore, our response is guided by the principle of first, do no harm. This principle encompasses both potential physical and psychological harm. Therefore, before offering any preventive measures, a comprehensive and thorough consultation with a balanced consideration of benefits and risks should take place. The evidence-based decision aids provided by professional societies can enhance the decisions made by those seeking advice. How can we advise the individual seeking guidance? It is important to conduct a consultation in a way that enables participatory decision-making for the individual seeking advice. This requires comprehensive information provision, addressing their questions, and taking their preferences into account. This applies not only to the decision regarding the extent of risk assessment, such as whether to explore only familial or individual burdens, but also extends to the consideration of predictive diagnostics, including genetic testing. It is crucial that the individuals have sufficient time to absorb the information and make their own decisions. During the consultation, it is essential that the options presented are not seen as obligations by the individual seeking advice. Particularly, the decision-making process regarding genetic testing is open-ended. Several questions need to be clarified for the individual seeking advice. In addition to the responsibility for oneself, family responsibilities also play a role in the decision-making process. For instance, mothers might contemplate their children's future. Women in partnerships may consider the impact on their relationship, and young women might ponder the implications for their desire to have children. Engaging with the options is a process of becoming that orients itself toward the future. Experiences of the family and others who have faced or are facing the same life challenge are taken into consideration. Satisfaction with the decision can arise when the individual seeking advice can be certain that they are only asked or required to undertake what they believe they are capable of handling. Auxiliary communication. The collaboration between the physician and the individual seeking advice within the context of genetic counseling in high-risk situations is a significant challenge for both communication partners. The diversity of diagnostic, therapeutic, and preventive options requires a high degree of orientation, not only from medical professionals, but also from those affected and their families. Genetic analyses not only assess predispositions, but also have psychological and social consequences for those being tested and their relatives, directly influencing their life and family planning. Experience shows that inadequate communication and misunderstanding between the physician and the individual seeking advice is a major and burdensome problem that often leads to hurt feelings, frustration, or anger. What is routine for the physician is an entirely new life situation for the individual seeking advice. What is professional work for the physician is personal fate for the individual seeking advice. The most important instrument for guidance is the guides themselves. In a consultation conversation, it is not only the medical expertise of the counselor that is needed, but also their communicative competence as a significant qualitative determinant. Appropriate communication requires mastery of situation appropriate conversation techniques as well as interpersonal skills. In recent years, the concept of patient centered communication has gained prominence, emphasizing understanding and considering the patient's perspective at its core. Patient centered communication includes providing understandable information to the individual seeking advice regarding examination techniques, such as genetic analysis in cases of possible familial disposition, diagnosis, and treatment options, as well as patient centered, empathetic communication, even for unfavorable news. The concept of patient centered communication does not only incorporate the individual experiences, expectations, and fears of the patient or individual seeking advice into the physician patient interaction, but also aims to perceive and understand patients or individuals seeking advice within their own psychosocial reference frames. Patient-oriented dialogue necessitates mutual listening and sharing. The concept of auxiliary communication implements these basic assumptions by not only providing factual information, but also attempting to comprehend the individual's reference system and experience, including its impact on their life. The guiding attitude is patient-oriented rather than centered on the perspective of the advisor or expert. The advising physician does not need to agree with or find everything the individual seeking advice expresses to be good or right. What is crucial is that the advisor does not find it at all, neither positively nor negatively. This non-evaluative stance is a prerequisite for the individual seeking advice to open up without fearing rejection. Furthermore, neutrality ensures a neutral stance of the advisor towards the individual seeking advice. If the advisor manages to accept the individual seeking advice with all their pain and fear and withstand it, it will also be easier for the individual seeking advice to accept themselves. The advising physician is a companion who presents alternatives or suggestions for solutions. However, the final decision always remains with the patient. Resolution of the case presentation. After receiving counseling, Julia decided to start by estimating her individual lifetime risk. The International Breast Cancer Intervention Study analysis based on the Tyrer-Cuzick model revealed that Julia has a 10-year risk of 3% and a lifetime risk of 24% for developing breast cancer. This indicates a risk around 3 times higher than that of a woman with a normal risk. This assumption considers that her sister's breast cancer status is unknown. However, if her sister were found to have the BRCA1 gene, Julia's 10-year risk would be nearly 18%, and her lifetime risk would be close to 48%, indicating a nearly 5-fold increased risk of breast cancer. Due to her sister's breast cancer diagnosis at the age of 33, Julia meets the criteria for undergoing genetic testing herself. Consequently, Julia is confronted with the questions formulated in Table 2, which we, as the advising physician, can help her address by providing factual information and appropriate communication techniques. It is ultimately her decision whether she wants to proceed with genetic testing, opt for intensified surveillance, consider prophylactic mastectomy, or choose not to undergo any of these measures. Conclusion for clinical practice. Asymptomatic women who are concerned about an increased risk of breast cancer due to family history should first receive comprehensive and detailed counseling, including a discussion of the benefits and risks of diagnostic and preventive measures. Since these individuals are not patients, but healthy women seeking guidance, the principle of non-maleficence takes precedence. In cases of high-risk situations, besides prophylactic mastectomy, intensified surveillance, following clearly structured recommendations of the relevant professional societies, is an established approach. These measures should be carried out at specialized centers within the frame of quality-assured programs. The focus should be on considering the individual preferences of the women seeking advice. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.